Sparkly. And then wave to the camera so I can prove your
Oh.
ear. Real
Oh.
people. I'm sorry. Okay. So thank you for coming. I'm Bianca Holmes, and this is my senior project, quality improvement project on protecting maternal mental health. Graduated for my BSN program. Yay!
Woo woo. Congratulations, Bianca.
Thank you. So this project, my abstract, this project was a review of level 4 and greater peer-reviewed research studies. This research was used to build and identify a plan to identify mothers that are at risk for postpartum depression, anxiety, and PTSD, to implement a plan to support these mothers and to improve outcomes for mothers and children. The participants of this project would be mothers that were diagnosed with high-risk pregnancies, had traumatic births, and babies admitted to the NICU. The data that was analyzed showed that mothers who were screened earlier in the pregnancy, even in the antepartum period, because they were high risk, their babies had better outcomes in the long term, and they were identified as being at risk for postpartum depression sooner than their 6 to 8 week visit. These moms that were part of programs that intervened early showed that they had, or reported that they felt more empowered to take care of their babies. Their babies had longer exclusive breastfeeding periods, they slept better, and they gained weight faster. So first we'll start with the basics, the signs and symptoms, some of the signs and symptoms of postpartum depression. And the biggest ones are the difficulty bonding with baby, withdrawal from family and friends, loss or increase of appetite, changes in sleep, feeling of hopelessness, guilt or shame, and self-harm or harming baby. So the big part of this program is the fact that when sometimes we think about postpartum depression, we don't take into consideration the effects that it has on the baby. So it affects the mother, but it also has been proven to affect the baby in, my little thing not working. Okay. So babies with moms who have been diagnosed with postpartum depression or mood disorders have been proven to be fussier, harder to calm. They have cognitive delays and speak later. They have behavioral problems after 1 year of age, and have been proven to have lower IQs after 4 years old. Okay. So another reason why this is important, because moms who have healthy babies have a rate of 13 to 18% chance of being having symptoms of a postpartum mood disorder. And admission to the NICU increases a mom's chances of postpartum mood disorder to 28 to 70%. You know, and that variables go, like the range is because of you have to add the variables of the delivery, was she hospitalized during the pregnancy, how bad is the prognosis for the baby, and how long does the baby stay in the NICU. The longer the mom is in the hospital and the longer the baby is in the hospital, more health issues for mom and baby, increases her risk in the intensity of the symptoms. So some risk factors for postpartum depression and mood disorders are a history of postpartum depression, a family history of mood disorders or depression, complications during the pregnancy, such as preterm labor, short cervix, gestational hypertension, gestational diabetes, health issues in the newborn, so any of our babies who are IUGR have congenital problems. This adds on to the mom's chances of these issues. multiple gestations, and a traumatic birth. Traumatic birth including uncontrolled pain during labor, a shoulder dystocia, an unplanned cesarean section, and etc. So diagnosis of postpartum depression. Signs and symptoms for postpartum depression can begin anywhere from in the prenatal period. Most instances begin within 72 hours of delivery, but can go from anywhere to a year before these symptoms begin. Only 11% of mothers with term newborns have those symptoms in the first 72 hours. The rest of our moms, which is the greater most of them, will have symptoms after the 72 hours. So this is after discharge from the hospital. And they won't be seen again by a medical provider until their 6 to 8 week follow-up at their checkup in the postpartum period. So for that 6 to 8 weeks, they could have the signs and symptoms, helplessness, lack of sleep, and haven't had the opportunity or know to speak to anybody in that time period, which could just further exacerbate their issues or symptoms. So the objectives of my project were to educate the staff on the importance of assessing parents or moms for the maternal mental health in the perinatal and the postpartum period, to explain the need for continued assessment from the perinatal period all the way to the postpartum, especially of babies in the NICU, to educate staff on coping mechanisms that can be taught to mothers while they're in the hospitalized for their pregnancy on our high-risk pregnancy unit, to teach staff to be able to identify risk factors for these perinatal mood disorders and postpartum depression, and to educate staff on the effects of these disorders on the babies, because and within our building, we have a high-risk unit, a postpartum, a labor and delivery, and a NICU. So as a whole, we can protect the family as a unit. So part of the rationale for me choosing this program is because of the increasing rate of our preterm births. Since the 80s, it has increased by 13% preterm births. In African American mothers, the preterm birth rate is 14%. Hypertensive disorders in pregnancy, gestational diabetes, and all high-risk pregnancies and complications have all increased since 1990. So because all of these are increasing, we're also having an increase in postpartum depression and mood disorders. As of right now in our building, we don't have a assessment set up for NICU parents. They come to visit their mom, we're assessing baby, getting updates on baby, but we don't have anything to follow up on how mom and dad are doing. And the baby's gonna go home with this mom, so we need to make sure that mom's taken care of as well. And in our standing orders for moms that are admitted to the high-risk unit, they can be there for anywhere from a few days to months. When I worked high risk, we had patients that were there from 20 weeks until delivery at 32 or 35 weeks. So that's 15 weeks in the hospital where which alone every week increases their chance for anxiety and depression. And we need to focus not on just the physical aspects of their pregnancy, but also their mental health. Because once we send them home, they may not know what it is that they need to speak up about how they're feeling. So my PICO question for this that I formulated was, will the formation of a maternal mental health team decrease the amount of time between the beginning of symptoms in a postpartum mood disorder and the intervention of high-risk pregnancy mothers and NICU parents? This is some of the research that I read that I helped build my project around. One of the first ones I read was about Cole et al. This research project was a monthly screening of high-risk mothers and NICU parents. They had a 96.5 compliance rate where they screened parents using the Edinburgh postnatal screening. They were encouraged staff by using screensavers like this on the computer to remind staff to ask parents or ask patients about their symptoms. They did monthly employee compliance updates so that staff could feel it's important to keep staff involved with it, to know that what we're doing is important. And they included part of the discharge packet, not just about diapers and health about the baby, about maternal health. When they started this assessment during the postpartum period, so that 72 hours that mom's in the hospital after delivery, they found 27% of moms that were discharged and had high-risk pregnancies all showed signs of mood disorders before they left, so signs of anxiety or depression. 8.8% of these mothers showed symptoms of major depression. My second one was based on mothers of low birth weight infants. So these were moms who were hospitalized with babies that had IUGR and were admitted to the NICU with babies less than 32 weeks. They were educated in coping skills during the perinatal period because we already knew that they were going to have to be delivered early. They were educated on the signs and symptoms of mood disorders early in the pregnancy, so they kind of knew what it was that they needed to report to their providers or nursing staff. And they were already educated in resources such as websites, support groups, and the staff that they could speak to. The mothers that participated in this study reported less symptoms of anxiety and depression at the end of it than the mothers who did not participate in the program. This one was one of my favorites because it was all nurse-based. So this program was completely family-centered. Like I said, we have to focus on the family as a unit, not just mom, not just baby. Nurses were trained in identifying factors of stress, such as income. If we're hospitalized for long periods of time, how are we feeding our other children? How are we paying our bills for our other children? The fact that we're stuck in a room and not able to, worrying about our unborn baby. Those are all factors of stress. They set up a listening visit. So these listening visits were times that were available to parents whose babies were in the NICU, where they could sit with not a counselor, not a therapist, because of the stigma of mental health. A lot of times if you tell people, would you like to speak to a social worker, would you like to speak to a therapist, they're already worried that you're going to take their baby from them, or they're going to be diagnosed with something or stigmatized. So these listening visits were completed with the nurses. The nurses were trained in counseling and listening skills, and so parents were given the opportunity to talk about what was going on in their life, how they felt about their baby's care, how they felt about their own health, and about and screen for any signs of anxiety or depression. So this is an example of the Edinburgh scale. So parents that scored less than 12 were just reassessed at the next visit. Parents or moms that got a 12 to 19, they were offered one of the listening visits and offered to speak to one of the social workers to be given the resources to maybe speak to a therapist or somebody outside of the hospital if they felt like they needed to. Anybody greater than 20, a score of 20, was automatically put in contact with a social worker so that they could get the ball rolling on a referral, because a lot of times therapy and psychological treatment isn't covered in their insurance. It's for our low-income mothers. This is a chart they had that I liked about the rationale of using nurses rather than other ancillary staff, because the parents that were involved with this studies reported that they felt safer and more comfortable speaking with the nursing staff, people that they had been involved with throughout the pregnancy, than they did speaking of strangers from outside the hospital. Oops. This one was about teaching guided imagery to our moms in a level 3 NICU hospital, which is what we are. So all of these mothers were at risk for delivering before 32 weeks. While in the antenatal unit, they were given packets and they made a video that taught moms how to do guided imagery. So during an 8-week program while they were in the hospital, they were encouraged to go over these guided imagery videos every day. And then they would move on to the next video throughout the thing. throughout the 8 weeks, they tested their saliva for cortisol levels, which tells us about their physical stress. The moms that did the guided imagery program had lower cortisol levels at the end of the 8 weeks. These moms also had, I don't want to say heavier babies, but their babies' birth weights were higher than the moms that did not participate. They also had decreased mental stress scores, decreased symptoms of depression. Their cortisol levels were lower, and the babies did better at delivery. So my recommendations after reading all of this research were to collaborate with the psychology staff, nursing, involving all of the nursing units, antenatal, postpartum, and the NICU, the obstetric team, neonatology, and social services to build a packet of how to take care of our moms and our babies. I want to build a maternal mental health team. This mental health team will be, again, because of our research that patients do better with nurses, be built of nurses either as a volunteer, at the beginning as a volunteer or a committee system. These nurses will be given extra education in counseling and talk therapy. With our moms that are on the high-risk unit for greater than 2 weeks, they'll automatically be visited by the maternal mental health team and be given bedside education on coping mechanism resources that they're available to them during their pregnancy or if they're discharged, and symptoms that should be reported to staff or to the doctor. Just like we have diabetes educators, we teach them about doing their insulin or taking their blood pressure, we should also go ahead and start this while we have the time and we have them in the hospital. So again, I think I just touched on this. So in the perinatal period, this would be our high-risk moms and our labor and delivery, or not high-risk moms, high-risk nurses in labor and delivery. For every mom that's in the hospital for greater than 2 weeks in hospitalization, go ahead and get that maternal mental health team to visit them. Provide the nursing education to them, and do weekly surveys while they're here hospitalized with the Edinburgh postnatal depression scale, because it also works during the antenatal period. During interpartum, we already chart, time of delivery, blood loss, and everything else. I feel like it's also important because of the long-term effects that we go ahead and acknowledge if mom has a traumatic birth or a difficult delivery. Did she have a shoulder dystocia? Was there an unplanned cesarean section? Did she have a hemorrhage and inadequate pain control? All of these put her at risk for anxiety, PTSD in the postpartum period. And a lot of times, I don't think we stop and think about how scary what's 5 minutes probably feels like an eternity to them while they don't understand what it is that's going on. We rush into their room, they're very vulnerable. And that has a long-term effect on them, which can turn into a mood disorder. So prior to discharge of moms like these, I want the maternal mental health team to meet with them. Just go over, review, ask them if they have any questions that maybe they didn't think about in the moment that they were in labor and delivery. So that we can go over that, answer any of their questions, refer them to their doctor so their doctor can answer those questions with them, and go ahead and get the ball rolling on resources and support systems for them before they're discharged in the 72-hour period. All the postpartum nurses, go ahead and do the same thing, but also we're going to do an Edinburgh scale on all of our moms, just because even if they didn't have a traumatic birth, there is still the chance that we might miss somebody. Add the postpartum depression education to the discharge packets, and go ahead and add resources such as websites and phone numbers to call so that they have that available to them at home if they don't feel comfortable talking to staff. Our NICU moms, babies can be in the NICU for weeks, months. And the longer the baby's in there, the higher the risk, the higher our chances of our moms developing some type of mood disorder. If our mom has a mood disorder, we already covered that our babies could not do as well once discharged. So I propose that we do a weekly survey of the Edinburgh scale. Parents can do it once a week when they come to visit the baby. The nurses will follow up and look for trends in increasing scores. Increasing scores, parents can be asked if they want to meet with our maternal mental health team, be offered counseling with this team, and given again resources that they can follow up with. Because at this point the baby could have been in the NICU for 6 weeks and we still have another week 7 before they see their doctor. So the outcome of my project, I'm hoping that we can identify at-risk families sooner, rather than waiting to the 6 to 8 period where they may talk to their doctor about how they're doing mentally. Go ahead and add several steps to where we can identify them while they're in the hospital in our care. Provide education and support sooner. Go ahead and build up the foundation for moms to be able to feel empowered to take care of themselves. This provides families to feel more ready to take care of their NICU babies when they go home. And again, all of this has proven in other research studies to have longer exclusive breastfeeding, which is a WHO goal for the last 2 years, improve eating in preterm infants, and improve sleep, and of course improve mother and infant bonding. The evaluation of this program, I believe, would take 18 months to construct it, educate staff, and begin implementation. I believe we would evaluate this program by surveying the staff on how we feel that we're doing. Are we connecting with our moms? Do we feel like we're making a difference? Because if the staff feels like we're making a difference, we'll try harder. And then of course, the biggest thing to me is that we identify more mothers before their 6-week follow-up with their doctor. Every mom that we find before the 6-week follow-up that's already showing signs and symptoms of anxiety and depression is one less mom that's not suffering by herself for that 6 weeks. And then of course a survey of the families to see if they feel more empowered to take care of their baby before they take them home from the NICU. So again, just to go back over everything, our moms that are increased risk are cesarean sections, unplanned cesarean sections, preterm births, high-risk pregnancies, with at risk for postpartum depression, maternal mental health issues. I propose that we build a maternal mental health team and educate staff and patients and our nursing team on how to take care of these moms. And hopefully the outcome will be that we decrease the time between symptoms and treatment of our mothers, between the beginning of their symptoms and when we would begin treatment, longer exclusive breastfeeding, and improved maternal mental health. And that's all. Did anybody have any questions?
I think it was a great presentation.
Yeah,
When are we
awesome.
gonna start?
I'm into it. Let's do
I
it.
know. I
Thank
think it's something that needs to be done for real.
I do appreciate it.
Yeah. I'm excited.
Are there any other hospitals who, like locally, who
Who do
do
this?
anything close to this?
All of the hospitals that I read were in at like Ivy League colleges. So one of them was at like Vanderbilt, because they have a big obstetric team, and then one of them was England. But locally, I couldn't find anything where people followed up with moms that closely.
Yeah. I remember the only thing I was telling you about, like in California, we did the Edinburgh scale, but it was like for postpartum moms. But you were asking the last 2 weeks, have you had these symptoms? And if they scored a certain amount, they were required to have a site visit. But then it came into the problem where if you did get a mom who showed signs and scored so high, it was like trying to get the psychologist to come in at that point. They're like, well, are they suicidal? Do they have a plan? You have to document so much, and it's kind of like, well, since they don't have all that, just tell them to follow up. And I was like, well, how do they follow up? But I felt like maybe like the social worker could have came at that point
Yeah.
to give them resources, because at that point it was like, oh well, they're not showing they don't show that
Like
they
a
want to harm
dire need right
themselves.
now. Yeah.
So, just have them follow up.
And
And
that's-
it's kind of like missed, I feel.
Yeah, and that's like a really great point, because then that's why I really wanted to be nurses, because we're already here.
Yeah.
We understand that we've taken care of these moms for the whole 30 whatever weeks, and we want the best outcome for everybody. So that just goes ahead and stops, like the consult stays within the building, with instead of outsourcing it to somewhere
Right.
else.
For somebody just to like,
Brush them off.
right, because they're
And I
like, well,
feel-
no, they're not really.
Yeah, and I feel like, I don't know, I feel like it's very easy for us to understand how birth affects and how birth affects mental health, and how being on high risk, you see the moms and they just sit there and they're like, there's nothing to do, you can see it happening. And I don't feel like, they could, maybe they do, but I feel like because we don't get as many psych visits, and when we do get psych visits, it's like a serious issue, like she was saying, where you can see things happening, and maybe they would be, maybe they wouldn't have, or they wouldn't understand that being on high risk can cause depression, and these traumatic births can do this. They might write that off, not, just on, I don't know, maybe they just won't think about those factors as much as we would maybe.
Right, because one of the things
Because they
that
rarely come over here, and
oh,
then
yeah.
they might be like, oh, well, you've at least had a healthy baby.
Right.
They might
Exactly.
say things like that, trying
healthy
to
baby,
help,
healthy mother.
Right.
and they
Yeah.
might not think that, oh yeah,
They
no,
want
those
the
aren't
ER
serious
patient who tries
issues.
to hang himself, or
Right,
somebody
someone that
who's-
has hearing voices.
Yeah, they want that to
They
come,
don't
not
want this
just.
subtle, oh, you're feeling sad,
Right.
but
And they even tell, I think it was part of a discharge, I can't remember, but you tell them, because I remember in part of our discharge, you would tell the moms signs of postpartum depression and making sure that they had a support system. And we even talk to their significant other, like, hey, these are the signs that you can look to. But I feel sometimes the moms really don't talk to their significant others, because a lot of times the significant others are like, oh, you're okay, or they don't really blow it off. So we were educated to really let them know, if you don't feel like comfortable talking to them, make sure you at least call your primary OB.
Right.
But how many people do that? So.
Exactly.
and I feel like some of these factors are easily written off, or symptoms and signs, because you're looking at all new moms go through lack of sleep and fussy babies
Yeah,
and
you
college
just had a baby.
stages, and they'll be like, oh, this is normal, and they just kind of
And then we're in a
try and just
pandemic.
just hustle through it, and then it doesn't get better.
But I did have one mom upstairs. This is my first time having it here. I was talking to her, and she did say, she said, I'm feeling anxious, and I feel like my postpartum depression is coming on sooner this time. And I said, well, did you have it with your previous baby? And she said, yes, I did, and they prescribed me a medication, but I stopped taking it. And then I didn't tell anybody else about it because I didn't feel like bothering anybody. So she said, I went through it my second without saying anything, but it went away. But she said, this is my third. She said, I feel like it's coming on a lot more sooner, and it's like it's almost uncontrollable. So she was in there trying to do like metaphysical things. She had her crystals, she had her oil, she was meditating, she was doing what she could, but she was like, this time I feel it has come on too soon, and I'm really being affected. And so of course we went to the next stage. We made sure she didn't have we had a contract, and then it was another baby. So I wasn't familiar with what they do, but they said that they would follow up with her OB and maybe put her back on her Wellbutrin that she was on for the first one. I was like, what else could we do?
Right.
But,
If she felt like she had a team that would truly support her. And then too, I haven't heard one in a long time, thank goodness, but those moms that we hear about harming their children, a majority of those cases, all of those women had postpartum depression with the first baby. It was never treated or acknowledged. Maybe they said something to their spouse, and it was just kind of like, that's normal. You have a lot of kids, of course you're tired, and then by the end of it, they're in a full-blown, by the fourth child, a full-blown postpartum psychosis. Yes.
The ones who drown their kids, like some of the
exactly.
I can't
Or
remember
a
all those
shaking
ones.
baby, or
Yeah, they all had some postpartum depression. depression.
Or some
Who killed all
stressful-
5 of her boys or something
Yeah.
like that.
Mm-hmm.
With the long dark hair, I can't remember her name.
Oh yeah, she's scary.
Yeah, she was. But she killed them all. But she had postpartum depression.
She did,
Like,
and so
she
then it's
went
like
through
people
everything.
judge her, and it's like,
She was even admitted, but then they let her go. Then they changed her medications, but insurance couldn't pay for it, so she had to stop it. Stuff like that.
Mhm.
And
And I
2
feel
weeks
like-
later, so that's when she did it.
And I feel like, I mean, it's also maybe more of an older generation. I feel like now people are slightly more open, not saying everybody, but friends of mine are more open about talking about therapy
Right.
and depression.
Yeah.
But I do know lots of people in my family who, if they hear about someone suffering with postpartum, they're just like, oh, that's just, she's just lazy, or she's just
tighten up the bootstraps or whatever.
like
Yeah,
she just needs
Get it
to suck it
together.
up and get it together. Where it's like, no, it could be
something more serious. Mm-hmm.
It's kind of like that mentality. You have to be, well, did she try to kill herself? Did she take pills? Did she do this? Before anybody think there's a problem. You can't have this, like symptoms that are not so drastic before people think it's a problem.
To do something about it.
Well, we
I
all
like
got
it
to
very
get
much.
this going as soon as you graduate. Come on, do it.
Thank you.
Because we have our bereavement stuff, so
We
not
have
bad.
bereavement, right? And so
And that probably started something like this, like
Mhm.
Tanya was just like, these people need some help, and then the thing got going, and then now we have a whole.
a whole bereavement. Well, she's the one
Yeah.
woman
Oh, yeah,
team, but
but
still, it's something.
so
We have like a
much
whole bereavement cart and packet.
Kids and just like this.
Exactly, and these women sit up there for 8 weeks, and it's like we teach them to crochet, or if that, you know what I mean? Like, and that's great, something for them to do. It might be like, but not everybody's gonna want to crochet.
And then people can even have their family and support come and visit them now.
Exactly. So now
Like
it's
the
like,
one support they have is their husband who works 9 to 5 or whatever, who can come up there when he's tired and ready to go to bed and
Yeah.
don't want to hear anything. You can't have your sister come up, you can't have your brother, you can't have your kids come up. So
and then the NICU parents, like you just went through possibly this traumatic birth, have been hospitalized for weeks, and now you can only see your baby for 1 to 2 hours a day.
oh yeah. True.
And-
And don't get COVID, you can't see them at all.
And
Yeah.
I was interested on what you said. The longer the NICU babies are here, and the longer the moms are here,
The
which is interesting because we try and feel like it helps to keep the moms in house so they can be with the baby. Which, I mean, I don't know if that was a fact, but you know how you were saying if the mom stays here longer and the
If the
baby's
mom's-
in NICU,
right.
then it can exacerbate.
But then I read that with the moms that are here postpartum hospitalized, like so if they have to stay on like postpartum magnesium sulfate, they it led to moms feeling inadequate.
Yeah.
So that feeling of inadequacy just added to their feelings of not being able to see their baby, not being a good mother, not being suitable for this, and having a fear of taking their baby home or
I just thought of it because a lot of times we're like, oh, do you want to stay an extra day or two?
right.
Just to,
Be close to
since
the
your
baby.
baby's here.
Right.
I wonder if that goes along with this of maybe
And
not
one of
being
the
in
projects
that situation.
I read that I didn't cover in this, but I wrote about in my paper, was women that were on a high risk unit for several weeks, how they got like not Stockholm syndrome, but similar to where they felt institutionalized.
Well, yeah.
To where you hear about people getting out of prisons after a long period of time, like the beeping, they don't feel like they can sleep at night anymore because they're used to the sounds of the hospital. They don't feel safe in their room because they're used to people coming in and out of their room. No real
Checking on
security, of coming in and out of while in the hospital. So it's something we feel like we're doing best for baby and mom, but like we're not looking at a whole picture.
It would be harming. Or they could stay longer, but we implement more of this stuff or something.
Because medicine is best, and we don't think of the whole. Oh, you guys are great. Thank you.
Loved it.